Welcome back to the deep dive. Today we're tackling a topic that, well, it pops up pretty frequently, especially if you're prepping for exams like the MSRA.
Mhm.
We're doing a deep dive into guttate psoriasis. We've got
Mhm.
all the info here, and we're going to really pull out the absolute essential nuggets for you.
Exactly. Think of this as your high-yield shortcut. We'll walk through the core aspects of guttate psoriasis, just drawing from the material we have, to build a clear, sort of memorable picture.
Right.
The mission is basically to get you feeling well-informed on this specific topic, quickly and effectively.
Okay, sounds good. So let's unpack this. What is guttate psoriasis like at its heart?
Well, fundamentally, it's a specific type of psoriasis. But the defining characteristic, a thing that gives it its name, really, is how the lesions look.
Okay.
You see this sudden outbreak of small, red, scaly spots, papules or plaques on the skin.
Small red scaly spots. And guttate means droplet-like, doesn't it? That visual really helps.
It does.
What else is absolutely fundamental about defining it?
Crucially, especially if you recall, this form of psoriasis often follows a specific kind of infection, a streptococcal throat infection.
Ah, okay. The strep link.
Yes. It's classified as an immune-mediated inflammatory skin disorder. So the body's immune system is involved, and it's much more common in younger people, children and adolescents.
Right, the strep connection. That feels like a really critical detail. And there's a timing thing, too, isn't there? It doesn't just show up immediately.
Exactly right. The onset typically occurs about 2 to 4 weeks after that initial strep infection.
Okay.
That lag time is, well, it's very characteristic.
Okay, so maybe you can remember guttate sounds a bit like gut or throat, linking to the strep trigger, and then remember the lag. So guttate equals strep throat, wait 2-4 weeks, then spots. Something like that.
That's actually a pretty useful way to connect it, yeah.
Wow.
Now, shifting gears slightly to why this happens. The exact cause, well, it isn't fully nailed down, but the material highlights a combination of sort of genetic predisposition and environmental factors, and the biggest environmental trigger that's emphasized.
Let me guess. Strep.
Yep, you got it.
Yeah,
That streptococcal infection we just talked about.
So triggers are a big deal. And who's typically, presenting with this? Who gets it?
Well, based on what we have here, it's most common in children, adolescents, and young adults. So think under 30, often quite a bit younger.
Okay.
A prior strep throat infection is a major, major association. Other factors mentioned that increased risk include having a family history of psoriasis,
Right, genetics.
significant stress, skin injuries. That's the Koebner's phenomenon, where you get lesions appearing in areas of trauma.
I guess.
And certain medications are also flagged as potential triggers.
Medications. Okay, which ones should we be looking out for based on this material?
The source specifically lists antimalarials, lithium, NSAIDs, and beta blockers.
Okay, so key risks: age, young, family history, stress, skin trauma, certain drugs, and, of course, that recent strep infection. That feels like a very high-yield list for revision.
Definitely. Now, let's briefly touch on the pathophysiology. How does that trigger actually lead to the skin spots?
Yeah, what's happening under the skin?
The source describes an overactive immune response. Basically, the immune system gets dysregulated, and this triggers the skin cells to grow way, way too fast.
So the immune system just hits the accelerator on skin cell production, like a factory production line suddenly speeding up like crazy, leading to a pileup.
That's a great analogy, actually. That pileup is the scales on the skin spots. It's that rapid turnover of skin cells that creates those characteristic papules and plaques.
Okay.
And the source also points out, interestingly, that the exact mechanisms are still being researched, so there's still more to figure out about why the immune system reacts quite like this.
Fascinating. Okay, let's look at the bigger picture briefly. Epidemiology. How common is it, according to the material?
In the UK context provided, the prevalence isn't precisely documented, but it's generally considered less common than the more sort of typical plaque psoriasis.
Okay, less common than plaque.
Yeah. It does affect both children and adults, but it really reinforces that higher frequency in individuals under 30.
So, again, confirming that younger age group. Anything else the epidemiology section hammers home?
It mentions a genetic predisposition linked to specific HLA types, no surprise there, and again really stresses the strong association with a recent streptococcal infection, particularly strep throat.
Right.
And those triggers we mentioned: stress, trauma, Koebner's, and those specific drugs like antimalarials, lithium, NSAIDs, beta blockers, they're brought up again here, suggesting they influence who's more likely to get it.
All right, let's get visual. This is Obviously critical for spotting it. What does guttate psoriasis actually look like? Describe those spots for us.
This is where the name guttate really makes sense. You see multiple small red, scaly papules or plaques. The material specifically says they resemble droplets, and the size is a key descriptor, typically ranging from 1 to 10 millimeters in diameter.
Droplets 1 to 10 millimeters across. Yeah, that paints a clear picture. And where do these spots typically show up? Is it everywhere?
Primarily on the trunk, the limbs, especially proximal limbs, and the scalp. The material is quite explicit that palms and soles are rarely affected.
Okay, rarely palms and soles. Good distinction.
Yeah. The rash usually starts pretty suddenly in acute onset, often beginning on the trunk and the parts of the limbs closest to the body, and then it can spread, sometimes involving the face and ears too.
And are they itchy?
Yes, the rash is often associated with mild itching. Not usually intensely itchy, but definitely some itch.
Okay. And what about other classic psoriasis signs, like nail changes? You often think of nail pitting with psoriasis.
And this is a really important point for differentiating guttate from other forms, especially plaque psoriasis. Those typical nail changes, things like pitting, ridges, the oil drop sign, they're usually absent in guttate psoriasis.
Lovely. Okay, that's key.
The source definitely highlights that as a key distinguishing feature.
Right. So, quick recap of the presentation. Sudden onset, multiple small droplet-like spots,
Yeah.
110 millimeter, red and scaly, mainly trunk, limbs, scalp, often mildly itchy, frequently follows strep, and typically, without those classic nail changes,
That's a solid checklist.
that feels like a good summary.
No.
The source also adds that the rash can sometimes just clear up on its own spontaneously,
Mm-hmm.
or it might evolve. And interestingly, it can get better in summer and worse in winter. Seasonal variation.
Yes, those are important nuances about its course. It's also worth remembering that while most cases are clearly linked to strep, chronic cases can occur, and sometimes these aren't obviously tied back to a recent infection.
Okay, let's put this into context. A little mini scenario for you listening. Imagine you're seeing a patient, say a 16-year-old, had a bad sore throat, maybe tonsillitis, about 3, maybe 4 weeks ago. Now they've suddenly come in with this widespread rash. It's all over their back and arms. You look closely, lots of small, red, scaly bumps, maybe about 5 millimeters across, to say it's a bit itchy. You check their fingernails, toenails look totally normal.
Yeah.
Based only on what we've just discussed from the sources, what's really high on your list of possibilities here?
Well, that scenario pretty much perfectly describes a classic presentation of guttate psoriasis. It should be right at the top of your differential diagnosis list.
Which brings us neatly to that list of other things it could be. Given that presentation, what are the conditions the source material says we absolutely need to consider, the differential diagnoses?
Okay, yeah, you need to have a mental checklist. The source gives us plaque psoriasis, obviously, then pityriasis rosea, nummular eczema, sometimes called nummular dermatitis,
Right.
fungal infections like Pinia corporis,
Hmm.
lichen planus, drug eruptions, always consider those, viral exanthems, syphilis, specifically secondary syphilis, can have skin manifestations, cutaneous T-cell lymphoma, rarer but important not to miss, and pityriasis lichenoides.
Wow, that's quite a spread.
Yeah.
So how do those specific features of guttate we just went through help you sort of sift through that list?
That's exactly the key. You use the features. Think about plaque psoriasis, usually a larger, thicker plaques, often on elbows and knees, right?
Right.
And you would expect nail changes typically.
Okay.
Pityriasis rosea often starts with that single, larger herald patch before the main rash, and the rash pattern can be different, often described as a Christmas tree distribution on the back.
Right, a Harold patch.
Fungal infections might have clearer raised edges or some central clearing. Drug eruptions can be sudden, sure, but the appearance or the history might point elsewhere. It's really the combination of things for guttate. The sudden onset, that characteristic droplet-like look,
Yeah.
the distribution, trunk, proximal limb, scalp, the lack of nail changes, and that crucial strep history. That whole package helps narrow it down from that broad list.
That's a really helpful way to think about applying those features. Okay, so how do you actually confirm the diagnosis then? What investigations do the sources mention?
Primarily, the diagnosis is clinical. It's based on putting together that medical history, especially asking about recent sore throats or infections with the physical examination of the skin.
So talking and looking, mainly.
Exactly. The source really emphasizes that a good history is vital.
So tests aren't always needed.
Correct. A skin biopsy is generally not required for a typical case. You usually don't need it.
Okay.
However, some investigations can be useful in specific situations. Maybe if you're a bit unsure or you really need to rule out something else on that differential list.
Like what?
Well, dermoscopy, using that special magnifying light to look closely at the lesions, the source says it may help differentiate it from something like chronic pityriasis lichenoids.
Okay.
And serology, like checking blood for elevated antibodies to streptolysin O, ASO titers.
Oh, the ASO titer.
Yeah, that can support the diagnosis if you suspect a recent strep infection was the trigger. And sometimes maybe a throat swab for bacterial culture might be done if it seems indicated to confirm strep.
Got it. So mostly clinical. History and examination are key. Tests are more supportive, maybe to rule things out or back up the strep link with ASO.
Absolutely. So moving on to management. Once you're confident in the diagnosis, what's the approach? What do you actually do about it?
Yeah, the plan.
Well, the first piece of good news, which is really important to share with patients, is that most cases resolve spontaneously.
Oh, really?
Yeah, often within 2 to 3 months without any specific treatment at all.
That's very reassuring. So watchful waiting is actually a valid strategy sometimes.
Often, yes. Especially for mild cases. Now, for mild to moderate cases where maybe the itching is bothersome or you want faster clearance, topical treatments are the first step.
Like creams and ointments.
Exactly. Things like topical corticosteroids, emollients, which are just good moisturizers to help the skin barrier, and vitamin D analogs, those are the mainstays.
Okay. Now, the big question, given the strep trigger, should you give antibiotics, specifically to treat the psoriasis lesions? It feels intuitive, right? Treat the trigger.
It does feel intuitive, and this is a really, really critical point from the source material, one to absolutely highlight for revision.
Okay.
There is no strong evidence that treating the streptococcal infection with antibiotics will actually clear the psoriasis lesions themselves.
Why? Okay, say that again.
No strong evidence that antibiotics for the strep help the skin rash of guttate psoriasis clear up. Now, antibiotics might still be needed for the infection itself for other reasons, like preventing rheumatic fever if it's confirmed strep through.
Right, standard strep management.
Exactly. But according to this material, antibiotics are not a standard treatment for the guttate psoriasis rash.
That is a super important distinction. Could definitely catch someone out in an exam scenario. Antibiotics for the infection if indicated, but not primarily for the skin rash. Got it. What if the case is more severe, though? More widespread, or just not clearing up on its own?
For faster clearance or more severe cases, the next step often considered is UVB phototherapy. That's ultraviolet light treatment.
Light therapy, okay.
And the source also mentions something perhaps a bit surprising: tonsillectomy. Removing the tonsils may be beneficial for chronic recurrent guttate psoriasis that seems clearly linked to strep tonsillitis.
Taking the tonsils out for chronic skin spots? Wow, that really underlines just how strong that strep trigger link can be in some persistent cases.
It certainly does. It's usually reserved for those difficult recurrent cases, though. Finally, the source just notes that research is ongoing, specifically mentioning the role of interleukin-17 IL-17 as a potential target for future treatments, again, pointing towards that immune system involvement.
Okay, so main management points. Most cases clear up on their own. Topicals for mild moderates. Phototherapy for faster clearance or severe cases, possibly tonsillectomy for those specific chronic, recurrent, strep-linked cases, and crucially, antibiotics not routinely used for the skin lesions themselves.
You've got it. That covers the main approaches. Now, looking at prognosis, what's the likely outcome?
Yeah, what happens long-term?
Well, as we've said, the natural course for the acute episode is often resolution within weeks to months.
But it doesn't always just vanish forever,
Yeah.
right? What are the potential downsides or future issues?
Correct. Recurrent episodes are definitely possible. Someone might get another flare-up later on, maybe after another infection. And there's also a known risk of progression to chronic plaque psoriasis, that more common, often lifelong form.
Ah, okay, so the guttate episode might be a one-off,
Yeah.
or it could come back, or it could sort of morph into standard plaque psoriasis down the line.
Exactly. It can sometimes be a precursor.
Are there any factors mentioned that suggest a better outcome, at least for the acute episode clearing up?
Yes, interestingly, the source notes that being younger and having high ASO titers, those antibodies confirming the recent strep infection, are actually associated with a good prognosis for the guttate episode resolving.
That is interesting. So if you see high ASO in a young patient with guttate psoriasis, based on the source, what might that suggest about their immediate outcome?
It might suggest a better chance that this particular rash episode will clear spontaneously. Yeah.
And what about scarring? Do these spots leave marks?
Scarring itself is uncommon. What you might see afterwards is temporary changes in skin color that's post-inflammatory hypo or hyperpigmentation.
Lighter or darker patches?
Exactly, where the spots were, but that usually fades over time.
Okay. So generally resolves, but watch out for recurrence or progression to plaque psoriasis. Younger age and high ASO seem to be good signs for the acute episode.
Precisely. And finally, let's just quickly cover potential complications.
Okay, what else can go wrong?
Well, the main thing, which kind of overlaps with prognosis, is that slightly increased risk of developing chronic plaque psoriasis later on, that progression risk.
Right, we covered that. Any more serious, but maybe rarer issues?
Yes, rarely guttate psoriasis can trigger more severe, unstable forms of psoriasis, like generalized pustular psoriasis or even erythrodermic psoriasis.
Which are emergencies, right?
Yes, those are much more widespread and potentially serious conditions needing urgent management. Much rarer, but important to be aware of.
Okay.
And the source also mentions iatrogenic complications problems caused by the treatment itself.
Side effects.
Exactly. So, for example, using topical steroids inappropriately, especially potent ones, for too long, can lead to skin thinning, cutaneous atrophy, visible small blood vessels, telangiectasia, or lighter patches of skin, hypopigmentation, where the cream was applied.
Right. Common steroid side effects.
And phototherapy, like PUVA, which involves taking a sensitizing agent, can have side effects like nausea, vomiting, or making the skin very sensitive to sunlight.
Okay, so the main complications to think about are progression to other forms of psoriasis, those rare but severe types like pustular or erythrodermic, and then the potential side effects from the treatments themselves. That seems to round it out.
Yeah, that gives a pretty comprehensive overview based on the sources we have, hopefully breaking it down like that, definition, causes, risks, how it works, what it looks like, what else it could be, investigations, management, outcome, and complications. Makes it much more digestible for your revision.
Absolutely. And just to hammer home those really high-yield points again,
Yeah.
that critical link to strep throat and the 2-4 week lag, remember that? The characteristic small droplet-like spots, 110 millimeters. The distribution. Trunk, limbs, scalp, but usually not palms and soles. Mild itch. And crucially, usually no typical psoriasis nail changes.
Don't forget that one.
And that key management point.
Yeah.
Antibiotics might be needed for the strep infection itself, but not primarily to treat the skin lesions.
Spot on.
Okay, here's something maybe to chew on as you integrate all this knowledge. Given how strongly guttate psoriasis is triggered by a specific common infection like strep throat, what does this particular condition tell us about the wider complex relationship between infections and triggering immune-mediated or even autoimmune-like responses elsewhere in the body? It's quite a fascinating example, isn't it?
It really is a window into immunopathology.
Definitely food for thought.
Ah.
Now, if you're looking for more free MSRA revision resources, you know where to go. Visit freemsSRA.com.
And for the full premium revision toolkit, head over to passthemsmra.com.
Thanks so much for joining us for this deep dive. Keep learning.